Let's bring in Raywat Deonandan. He's an epidemiologist, assistant professor at the University of Ottawa. Good afternoon, and thanks as always for joining us. You're becoming our house epidemiologist. I never thought we would have one.
Pleasure to have that role.
What are your thoughts from what you heard from Dr. Rusin, Manitoba's top doctor, and some of our numbers and the results we're seeing here so far?
Well, you have a diminishing number of new cases, which is good. The number of new cases has been low and stable the last few days. So if you look at a curve of the total cumulative cases, it seems to be edging towards a plateau. So I'm cautiously optimistic about Manitoba. You have a small number of cases, which is appropriate for your population size and your density. So I think if you guys keep doing what you're doing, you should be, I want to say, in a good position in a couple of weeks. I'm cautiously optimistic.
Are we testing enough?
No one's testing enough. And the problem that Manitoba has, the same problem that other provinces has, is you can't get enough tests. There is a global shortage of the reagents needed to process the tests in the labs, and only a particular number of labs have the capacity to undertake the testing. Even the swabs themselves are in short supply. As a result, you have to deploy the tests strategically. And right now, it looks like you're deploying them the way they should be deployed amongst those who are mostly symptomatic, because we have to figure out what to do with those individuals, so they should need to be isolated or treated differently, and in long-term care and correctional facilities, because that's where the explosive outbreaks occur. So in places where people can't get out, like in a prison or an old folks' home, you got to make sure that everyone there is not spreading it further. So that's the right way to use testing in your particular circumstance. Ideally, we'd be testing everybody, but we can't.
What about testing after the fact? I saw a doctor from southern Florida who had a little testing device. It almost looked like a pregnancy test, if you will. And he was sick in January, and he said he tested to see if he had the antibodies. Now, at the very least, when this is in our rearview mirror, should we be checking to see who has those antibodies?
100%. This has to be part of our strategy to return to normal. That's called a serology test or an antibody test. Now, there's a whole series of those serology tests coming down the pipeline, and Health Canada is testing them out right now. Other countries have already deployed them in their countries, but they come with some challenges. For example, we're assuming if you've got the antibody, you're immune. We don't know how much of the antibody you need to confer immunity. We don't know if a coronavirus antibody will be specific to this coronavirus, or maybe you're detecting the common cold, which is also a coronavirus. These things have to be worked out still. But when they are worked out, this will be an extremely powerful tool that will get us back to something resembling normalcy pretty fast.
The British Medical Journal saying within the last few days that 4/5 of the COVID-19 cases out of China were people that were asymptomatic. Have you seen that data? And if you have, is that concerning?
I have seen it, and it can be concerning, but it's not surprising. We know that a lot of transmission already is done by asymptomatic people. Now, the data out of China is a little unclear. We don't know if they did random sampling to get that percentage. We don't know if they're suggesting that these people would never become sick, whether they're always going to be carriers, or whether they're referring to those who are asymptomatic until they become symptomatic. But what we know is that asymptomatic people currently who eventually become sick do pass it on. And we do think that a very large percentage of the cases in China were infected via people who weren't sick yet. I will say this: if it's true that there are people walking among us who are infected and will never become sick, or were infected and never became sick, that might be a good thing, because it might mean that we are closer to herd immunity than we thought. It means that this thing has been circulating our population for some time, so maybe there's more innate immunity surrounding this than we first thought. It isn't all necessarily bad news, but there's a healthy dose of bad news in there.
Have you seen any data on whether this is hitting smokers or people in areas where smog is a big factor, harder than non-smokers, and places where we just have cleaner air in general?
Most of the comorbidity data suggests that any underlying respiratory condition is bad. That includes old age, that includes COPD, that includes asthma, that includes smoking for sure. It includes obesity, it includes diabetes, hypertension, anything that prevents your lungs from functioning in their best optimal capacity. I don't know about pollution, though. That's a good question, and I wouldn't be surprised, but pollution is highly correlated with other kinds of bad urban behaviors, so there's an element of general unwellness that's wrapped in there. But the best prognosis or the best prescription around it is keep yourself as healthy as you can, eat healthfully, exercise, sleep well, drink lots of water. Do not smoke. Stop that smoking right now. These are important things that we can all do to protect ourselves.
When we look at Ontario, Quebec, American cities, New York, how much of this is population density oriented?
A fair amount is population density oriented. That determines the extent and rapidity of the spread. And this is the great curse of modern living. We can travel the world very quickly. Under the incubation time of a given disease, we can go around the world. We interact with hundreds of people every day. So this is a major concern, absolutely. In fact, it may be a reason that some of our more rural provinces, like New Brunswick, for example, might have a lesser transmission rate because it's harder to interact with people. It's definitely a concern. These urban centers are also travel hubs. So places like Toronto and Beijing and New York and LA. This is where a lot of flights go through from a lot of different countries. So it's not surprising that different sources of infection will arrive in bulk.
So how long do you think we're in this?
Has a role.
How long do you think we're in this?
That is the great question, right? All of the models suggest that globally, the pandemic will last about 2 years. Now, that's an estimate based upon the rate of spread and when most people will acquire some kind of herd immunity. But for Canada and North America in general, the models are suggesting that the current wave, if we continue to be disciplined with our social distancing, the current wave will begin to flatten out by the end of May, early June for most of the continent. And maybe we can start thinking about some degree of normalcy for the summer. But then the challenge is it's going to come back. There will be a second smaller wave, probably in late summer, early fall. So that's why it's important that when this current wave is abated, that we make the appropriate public health investments to prevent that from happening. And it probably means we're going to have to endure some degree of social distancing and eschew our large gatherings for the rest of the summer in order to prevent that second wave from coming.
Raywat Deonandan is an assistant professor, University of Ottawa, and officially now 680 CJOB's house epidemiologist. Thanks for your time. I appreciate it.
Thank you so much.